Dr. Umesh Kalane, who's got a large number of DMD children that he's following up. And yeah, who works in St. John's, who's a developmental pediatrician. Thank you so much for agreeing to do this, Dr. Nilia, to both of you. And a big thank you to Dr. Vineet, Professor Vineet, for agreeing to do this. He has a lot of interest in DMD. And there's lots of questions that were bugging many of us, which we are hoping that together we can solve. So I'm leaving it to writers. Umesh, you know that it's a fairly informal one between Dr. Neely and Dr. Umesh.
Yeah.
Yeah, I think Nelia has already introduced me, so I can. And should we start?
We'll go by what Dr. Umesh and Dr. Neela say.
Yes, please go ahead. Yes, you can start.
Please start.
Okay. So
please start.
Thank you, Dr. Anne, for giving me this opportunity to give this talk. I think I have learned a lot through preparing for this talk, so I hope I'll be able to convey the same. Okay, so yeah, so we know the care guidelines that was published in 2018 in Lancet. And what I have done is I've just taken some of those snippets for the psychosocial aspect of care for children with Duchenne's. And what they say very clearly is that all individuals with Duchenne's should be expected to live rich and fulfilling lives. That's saying a lot, especially looking at the reality of how we see these children live and the short lifespan that they have, but that is the expectation that we are called to have. And also, all patients and their families will need psychosocial support. I think it's not just might. When the diagnosis is delivered of a life-altering, diagnosis, definitely psychosocial support is required at that time. And also throughout the life journey, it's very important that that is kept as a priority and not by the side, because that's what makes the difference in the outlook through the whole journey of this illness. So the neuromuscular care team should include a mental health professional. I think that is an essential part of the team, because as a neurologist or as a pediatrician, from our point of view, we would try to support them, but no matter how much we spend time with them, it won't be enough. And it's always good to have somebody on the team who can take care of this part of their health. We should have access to detailed neuropsychological evaluations, especially when we see cognitive delays, when we see emotional behavioral dysregulation. And also we should be able to look after their social skills. These children go through a span from childhood on to adolescence and then even into adulthood. So it's important that we look after them through the range of their life. Once we have done psychological evaluation, it should be re-evaluated every 2 to 3 years. And we must always begin with a psychological evaluation at baseline. That's easy to do, especially if you have a psychologist on the team. And whenever a patient comes and they're part of the multidisciplinary team evaluation, as per protocol, that can be done once we have established these standards of care. Also, when a child is transitioning into adulthood, it is important that we do neuropsychological evaluations for functional independence. In our Indian context, of course, independence, even in early adulthood, may be a little distant for now. But this is, of course, guidelines from Europe. So something we can aim for to happen in India as well. This is also a small table that's taken from the same 2018 guidelines. There are a lot of newer things that are happening now, but essentially that in the ambulatory stage or early childhood, we must do neuropsychological evaluations. Less than 4 years should be developmental. After 5 years, neuropsychological evaluation should be done. Speech and language pathologists is an important part. They do have significant problems with expression, speech, learning, which we will come to in the subsequent slides. And also a social worker is a key part of the team who needs to reach out to the family whenever it's required. Also, when they are early non-ambulatory stage, again, these evaluations need to continue. And in the late non-ambulatory stage, of course, we have to support them with speech and language, and the whole family, as well as the family also undergoes trauma along with the child. So, what are the various interventions that we can do for them? Well, we can refer to psychotherapy or psychopharmacology that can be done. We can implement formal accommodations at school. It's very, very important that these children go to school. We can provide parents with resources, teachers with resources, and other school personnel. We can educate them, which is a part of the whole protocol for a child with Duchenne's, and provide parents and patients with resources, refer to a psychologist, encourage patients and families to stay active and engaged. Social isolation is sometimes a reality for these families. So, to be able to engage them in community activities, whatever is relevant to them, must be encouraged and promoted. Also, promote patient self advocacy and independence. Of course, as they grow older, we need to assist them with continuing education and vocation. These children, just like any other child, any other person, needs to have a goal in their life, and education and a vocation is a valid goal for them to find meaning through the pain and suffering of growing up in this altered lifestyle of physical difficulty. And also, these children need to be accommodated for jobs. These things are happening. We have children with Duchenne's who are IT engineers. We have them who are doctors. These are Duchenne's, not even Becker's. So that's very important for us to go aim for that. Whether we achieve it or not depends on each individual child, their family, the resources, but something to set as a goal. Also, to arrange for home health care services if the patient's health is at risk. It seems like a lot, but it is possible depending in what service area we are to provide these cares. So, what are the other psychosocial care for the family and patients that we can do? First is we need to be aware of DMD specific neurodevelopmental and neuropsychological issues. I will touch on that briefly. I hope I can do justice to the time. Yes. And refer to a psychologist, like we said, speech and language pathologist, very important for suspected delay because the interventions will make a difference. Help family with special education needs, identify community resources, and help initiate discussions about transitions of care. These discussions need to be started early. By the time the child is around 12 years old, 12, 13, 14, these discussions about transitions of care into adult care needs to be started early. And also to talk about their, aspirations into adulthood. What would they want to become? What would they like to do? All of these conversations need to be had with these children, and also ensure that adults with DMD have completed advanced directives. They have people who can sign for them on what they would like to happen if an event were to happen. Would they like to be in ICU or, intubated or CPR given? All that discussion needs to be done. Every visit in the clinic, we need to screen them for mental health and their quality of life. Screening can be informal. We don't need to do any comprehensive assessments, but it is essential that we do it. It can be done by a social worker, clinic staff. It doesn't have to be anything formal, but an informal screening is important. If in the screening we find that the patient has definitely got some psychological or mental issues, then we must refer to a psychologist or a psychiatrist. We must assess, especially as these children grow older into adolescence and young adulthood, whether they are having suicidal ideation or any acute injury risk that they may carry, so that we can be addressed in time. And of course, emotional adjustment for the caregiver is important and should be monitored, and intervention support offered as needed. Also, not forget the siblings of patients with DMD. I mean, they go through their own pain and suffering. Sometimes both children with DMD have Duchenne's. which is, I mean, it's really, really sad when that happens. But even siblings who are normal of children with DMD, because of neglect and so much of attention that's given to the child, so they go through their own pain, which needs to be addressed as well. This is again a chart taken from 2018 Lancet, which talks about adults with Duchenne's. I really like this chart. It has been quite directional for me in my center here, looking at transportation, looking at healthcare, how to help them with their ADLs, looking at education and employment, relationship with others, housing, how to modify their home, make it accessible, looking at their washrooms, looking at kitchens. All of these things are a part of the guidelines for looking after young adults with Duchenne's. So there was a paper recently looking at the natural history model. This is fairly recent, 2 years ago, from the project Hercules. And they have come up with this, breaking it down to 8 stages. Previously, there were 3, then they became 4, and now there are 8 stages. So just to briefly mention, you have early ambulatory and late ambulatory, and then you have this in-between stage, which has got a lot of psychological and social relevance, which is a transfer stage when the patient is no longer able to walk freely and yet is not fully dependent on a wheelchair. And then you have no hand to mouth function with no ventilation, that's stage 4. And then you have stage 5, stage 6, depending on whether there's hand to mouth function is still present or patient is on ventilation, nighttime ventilation, or full-time ventilation. And of course, stage 9 is death. Sometimes they don't follow in a linear fashion. That's why they have divided into 2. You may have 5 and 6, or either of them. It happens. Sometimes patients may go straight to nighttime ventilation while still having a hand-to-mouth function intact. This is again a chart which is available, which talks about the criteria by which we can label them into these 8 stages. The reason I put this, it helps us in our classification of patients with Duchenne's in a more fine way to study them more carefully and to provide for their needs as they go through these different stages. These are recent papers. I know Dr. Ann will also be mentioning and going through this in her talk after this. But basically, the BIND project, which was done essentially to look at brain, which is our topic for today in dystrophinopathy, again looked at the same stages and have come up with very clear guidelines on what needs to be done with each stage and how they progress. So, and this is a chart that looks at their age. Here you can see their age. This is with age, and this is with the forced vital capacity predicted. So you can see in early ambulatory going down the stages, it's a fairly linear thing which happens with age. And the forced vital capacity keeps reducing as as these stages also progress. So these stages are quite reasonable. And this is a chart that looks at steroid use across various health states. And here we can see 93% to 100% usage of steroids. But as they grow into full ventilation towards that time, then of course the use of steroids decreases. But till even in the ambulatory phase, steroids is being prescribed now much more than what was being prescribed previously. And the cardiac ejection fraction, the heart function, we can see that it is stable all the way to the end. Of course, these are patients who are on standard of care. So this is not for patients who are not on standard of care, but these graphs are for those who are part of standard of care treatment and getting all their protective medication. This is another table. This is looking at now that we understand the stages, the neurodevelopmental and behavioral and emotional symptoms that these patients go through. So this was a sample collected of 700 DMD patients and 70 BMD. And we can see that they had autism, ADHD, learning disability, language and speech delays, global intellectual delays, tics, behavioral emotional symptoms were obsessive compulsive disorder, emotional and behavioral dysregulation, anxiety, and depression. And all of these were fairly common. Of course, some would have been with overlap, so they may not add to 100, the percentages, but they are fairly common. I mean, these are not, this is something that we should be looking at in all our patients. This is a chart taken from PPMD's website, in which we can look at their sample. They had around 3,000 patients with Duchenne's, and from them, it was a patient self-reported incidence or prevalence of frequency rather of various behavioral and emotional diagnoses. So they said when they were asked in the questionnaire that they had ADHD, 10% had ADHD, 9% had Asperger's, and of course there was autism here, 7%. So large number of patients reported, self-reported that they were having these problems or they were diagnosed with these illnesses. And in learning and cognitive diagnosis, around 21% had speech and expressive and language delay. This is something that we all notice in our patients when they come, that there is definitely speech, especially expressive language. There's dysarthria, there is some degree of slurring. Those things are present in these patients. And of course, some have writing disability, some have reading disability, many have short-term memory problems. So these are not things that can be ignored, but can be addressed. This is again a chart from the same paper in which it shows that whether they were taking steroids or no steroids, depending on whatever age group they were, it was not significantly contributing towards the behavioral concerns. Because we do find once they're on steroids, they become agitated, irritable, but it is not a dominant issue in patients, and the benefits of steroids override these concerns. This is a paper on behavioral and learning concerns in DMD published in 2022. And here we can look at this 79 exon of dystrophin that we can see, and we can see different parts of it. And we see the one that binds to the actin, this whole actin binding area. We see the rod domain, and we see the 4 hinge 1, hinge 2, hinge 4, which are proline based areas, and we see the dystroglycan binding area and the syntrophin binding area. Now, this is important when we look at brain and dystrophin, because you can see here you have the DP dystrophin 427, and here you have 260 and 140, 116, 71. All of these have got relevance, as I will show in the subsequent slides. And if you have mutations in different parts of this, be deletion, all of these things, then certain types of dystrophins will be more missing. And this study per se also showed that in patients who were having dystrophin exon 63 to 79 missing, these patients on their behavioral analysis had 62% behavioral concerns, as opposed to others where they were almost the same, 50% or, so the ones who 1 to 44, it was a minority that had behavioral concerns and the majority were fine. But 63 to 79 showed 62% behavioral concern in this particular study. And learning concerns also similarly, and those who had mutations in exon 63 to 79 had 78% disproportionately higher learning concerns, suggesting that definitely the site of mutation contributes to their learning and behavioral problems. And this is the same paper again, which looks at behavioral as well as learning concerns. And yes, the age matters, but also, a large proportion of patients because of the site of mutation. Here, 9.54 was the odds ratio of those patients to develop learning and behavioral concerns. So definitely, I think it's quite clear that the site of mutation matters. There was some concern about the type of steroids taken as well. The prednisolone had more behavioral concerns than deflazacort. Coming on to some more recent insights in brain, again, this is through the BIND Group's paper. And they basically found that the deficiency of Duchenne causes intellectual disability in 22% of patients. Autism is seen in 6%, and ADHD is seen in, or attention deficit in 18% of patients. Here again, this is just the same protein. Of course, here you can see the shape of the protein where you have 427, which has got these hinges all the way down till here, even at DP71. And you can see that there are certain parts of the protein which are common for the muscle and for the brain. And the rod domain is here. So if you have some mutations around here, but this entire thing is able to connect with each other, it may not affect the brain as much, although the muscle does get affected. Whereas here you get to see the brain, the forebrain and the cerebellum. I will come to that, why these are important. And then you have shorter proteins in which this part is missing, and in the retina, in the brain, kidneys, peripheral nerves. So dystrophin is not present only in the muscle. I think we are all well aware of that. But this is a graph that kind of helps us to see that. I did not go to the muscle part, which is something we are very familiar with, but this is in the brain. Here we see the DP427 here, and how this connects to the beta dystrobrevin. And here it connects to the postsynaptic of the GABA receptors in the brain. So wherever there are GABA receptors, especially in the forebrain, that area, then we are going to have in dystrophin is missing or it's of poor quality. There will be issues with the inhibitory aspect of those particular networks. This is a similar thing that is situated here. This is DP140 that is there. And here again, we see it at the astrocyte foot plates of the astrocytes DP71, which is there at the astrocyte foot plates in the central nervous system. This is the Big Ten. Big Ten is this concept of brain in patients with dystrophinopathy. There are basically four main domains. This is, you have the executive domain, that's A, and then you have the academic domain, B, you have the emotional domain, and the neuropsychiatric domain, D. So in the executive domain, you have executive functions, working memory, intellectual functioning. This is the neurocognitive domain. And then you have reading, arithmetic in the academic domain, and anxiety, depression in the emotional domain. And then you have the neuropsychiatric in the in which ADHD, autism, and obsessive compulsive disorder comes. Now, this is very common in patients with dystrophin, and like we are seeing that certain mutations and certain proteins are essential for the brain functioning. And in patients with the lack of those will have emotional, some dysregulation in these parts. In this particular paper, they were able to show in the mice model on how when certain parts are missing, whether these are knockout mice or through chemical knockouts, that their motor functions, their emotional and stress reactivity, social behavior, cognitive functions all get affected. And but the beauty of this paper is also to show that despite these phenotypes, which were very well described, they were able to show, like in this particular aspect, that by replenishing those proteins, the activity was, restored. So here is an important part where if a patient has got 52 deletion, it's an out of frame deletion, and that is a Duchenne phenotype. And if we were to do 51 skipping, which is now currently what is available in the market, but 51 has got the promoter region for the DP140. So then DP140 will not be formed. So you will have DP427, but DP140 being missing will affect their cognition of these patients. So now in these patients, then if we would to do 53 skipping, and then you would have 51, which would then link to 54, and it'll become an in-frame mutation with both DP427 and DP140 being produced. So you would expect that their outcomes would be better. Of course, this is in a mouse model that has been studied, and it did show that it does make a
If you are
difference.
telling her that, can you
Okay, so this is the same group which recently published in Brain. And this is, I won't repeat this slide. It is very similar to what we just saw. Again, showing the same thing in the inside the brain, where the dystrophin has got a role both at the synaptic, postsynaptic section, and also in the food processes of the astrocytes. And here you have dystrophin, which causes GABA R clustering, DP427, DP140, like I showed, it binds the caveolin, and DP71, which is very important for dysbindin. So each of these, now we understand how they play a role inside the brain. And if you miss certain parts of these proteins, then it will have an expression inside them. Quickly coming on to intelligence of these children and studies that have looked at there. It's a very old paper here. It published in 2001 by Cotton, in which, of course, they showed that verbal and performance intelligence are reduced or decreased in patients with Duchenne's. They had around, I think, 1,200 patients samples that they had collected across multiple studies, which was done. This is a slide not from the same paper, but from PPMD's psychological paper for practitioners and for parents. Here we can see that in children who are less than 9 years, that their verbal intelligence quotient is more affected as compared to the performance intelligence quotient. But this kind of evens out as these children, are grow grow older. Their verbal intelligence quotient seems to gradually catch up. So that is an encouraging fact which we must keep in mind, that though these children, when we test their IQ when they are younger, they may fall below the range, but as they grow older, there is a chance that they may catch up with with the rest of us. So this is a paper from India. This is from PGI, the PGI group. And they looked at patients who had Duchenne's. Around 69 patients were studied, and they looked at a control group as well. The mean age was around 10 years. And they looked at their verbal intelligence quotient and found that patients with Duchenne's had, low average intelligence, verbal intelligence quotient. I mean, just on the lower side. And the control group was definitely far ahead. And of course, verbal subsets and performance subsets also showed the same thing. So showing that in India, at least both verbal and performance intelligence quotients are affected in our group. Of course, they did not follow it up with age, and most of them were just 10 years old. Quickly coming on to what are the strengths of these children with Duchenne's. They have good visual perceptual skills, and learning and rote memory is learning by rote memory is intact in most of them. From the weakness point of view, they have specific language impairment, which I will just show one slide on, and they have short-term memory, and they have difficulty with concentration. So when we are sending them to school, when they're educating them, it's important to be aware of this. Of course, it is a range, so we need to look at each individual child, and then make a decision. Around 40% of them may have, we may notice that they have expressive language problems. And that may be the first thing that we notice, even before we notice weakness. They may be late to speak. They may have problems with word finding, difficulty with fluent language production. They may have deficits in auditory working memory. And they may have, speech understanding is better than speech expression. So this is what we call specific language impairment. And this becomes a risk factor for reading problems later on in life. And we know how important in society to be able to read is. And there are various ways to go around it, how to educate them. If I have time, I'll come to that. So this is a publication by a parent project for Duchenne's by this is a psychologist who has published this paper, this document, and they have a lot of difficulty because of these weaknesses in completing tasks with time orientation, difficulty with initiative. They don't know how to start an activity. They have resistance to change, in adapting to change, to new things. They have difficulty switching from one activity to another. So when in school, it is not so much that they are unwilling to do activities, they're just unable. And that is why it is important to detect this early and then help these children in their schools and even at home. What can we do to cope with these weaknesses, especially when it comes to short-term memory problems? We can use shorter sentences. We can use visual cues. We can check whether he has understood what he has been told. We can ask him to reteach, repeat what he has understood. We can summarize and repeat the main information. We can introduce new information step by step and always repeat the previous step. Um, in school, they have dyslexia, which is much a higher risk for children with Duchenne's. They have grapheme phoneme conversion impaired. Cerebellum being affected, like I mentioned previously, also affects the dyslexia because of automatic learning. The Purkinje fibers are important in that. Technical aids also, as these children grow up and they become further non-ambulatory, will need more and more of technical aid, and reading is a skill that they will require, even if it is for typing. All of those things, even through when they type, it is important. And there are various strategies like early detection, early intervention. By age 4, you should have a speech therapist who would assess them. You want them to read aloud and have phonemic awareness. Maybe I won't go through the depths of this. This is all more of special education. But the reason I'm saying this, that there's a lot that can be done for each of these children. Dyscalculia is something that they all struggle with, and they have difficulty in measuring, to be able to tell the time using money. All of that becomes an important thing as they grow older. And as young adults, if they are not intervened early, then they are severely disabled when they become young adults. And there are ways to cope with dyscalculia. There are methods. Again, I won't go through it due to paucity of time. This is a small sample of patients that we did at our center. Here, we can see that most frequent genetic mutation we have is in exons 45 to 51. And the IQ range of our patients was from 50 to 112. And a significant number of patients, around 50% of them, have an IQ below average, less than 85, showing again that our subset of patients also have cognitive, along with their physical impact. What we also do for our children is we have this questionnaire which is available freely online, which we use when we go to their homes. We have a social worker who would visit them at their home. And this questionnaire looks at, 9 aspects: ADLs, positioning, transferring, mobility, comfort, emotion, social interaction, schooling, health, overall quality of life. And how do all of these items, score on the importance to the quality of life, and some more details about the patient. What we do in our multidisciplinary team when these patients are brought to us, we try to do these assessments in a short time, within probably around 6 to 8 hours. Different teams would come together to see these patients. And then we also have a special needs educator who would go to their homes in the city, because a large population of ours are within the city or nearby district. So we are able to do that for our children. This is our team. This is not the whole team, but this is all we could get together for the photograph. So I think I'll stop it here. Thank you.
Fantastic presentation, Professor Vineet. You have nicely elaborated all the facts, all the studies regarding DMD and brain and basically dystrophinopathies. So, Nelly, you can continue from here. Anne is there. Yeah. And you are not audible.
You're on mute.
Can you imagine that he is not pediatric?
Yeah, that's what I'm
Yeah,
wondering. So nicely he.
yeah, he's so much better. We should be doing so much more. You
Yeah.
make us feel encouraging us more, Dr. Vineet.
So,
You are encouraging me. Yeah. Thank you.
A
Dr.
few
Neela?
points to Vineet's presentation.
Uh-huh.
Vineet, thank you. It was very nice, and it was nice to see an adult neurologist go through everything that we see with our kids every day. So I think an important member of your team that you've missed out is a developmental pediatrician, because before jumping to the psychologist, I think it's important a developmental pediatrician sees, because see, some of these psychological assessments, neuropsychological assessments that you do in DMD children, the motor dysfunction also starts happening. And a lot of these psychometric tests also depend on them doing some writing, some reading, some puzzles. So we need to choose a test that is also appropriate for them, that they can do as their motor skills start declining, because we may not get the true measure of their IQ. So some of the comorbidities, you mentioned most of them, like LD, ID, but we see a lot of ASD, autism, and DMD. And sometimes, like you said, children, small kids come into the OPD with their parents with the chief complaint of a speech delay and poor eye contact. And then we notice these hypertrophied calves, and then we're like, okay, there's more to it than just, and that's like a double whammy, because they have ASD and they have DMD, and then sometimes because dystrophin is in the brain and it's required for brain development and neurodevelopment, sometimes we find there's epilepsy also. So there are a lot of, and these neurodevelopmental disorders never exist in isolation. So you may have ASD with ADHD, with ID, with LD, and then later as they grow up. So those are the neurodevelopmental disorders, because it starts at a young age. And then as they grow up and they're living longer, then depression, anxiety, OCD symptoms start coming in. So for the younger children, I think like Dr. Anne was also speaking about it. So like you were talking about, the GABA receptors are there in the frontal lobe. So frontal lobe affects the executive functioning. So definitely their memory, concentration, um, distractibility, decision making all comes from the frontal lobe. So they do have more ADHD, like about 30% have ADHD. And because these are children with a motor deficit, even though they're boys, they will have more inattention than hyperactivity. And if they do have hyperactivity, then we find that they have more frequent falls and more injuries. But as they grow older, not as they grow older, they have more inattention. So this gets missed because, like in school, they're considered lazy, or like the memory issues, they can't focus, they can't finish the task. So it's not just the cognition, it might be the inattention, which is part of the ADHD, but it presents a little different in these children. So I think methylphenidate, as I don't know if Dr. Anne is going to speak about it, does
Yeah,
help, but
I am.
yeah, we just have to keep monitoring the cardiac status and the BP, because they are also on steroids, both of which can increase the BP. Methylphenidate, when we use it, we have to be careful also, because it affects them. So these are the psychopharmacological measures that if you send to the psychologist, she may not be able to help you with that. So having a developmental pediatrician, I think, can assess what needs to be done, when it needs to be done, and how it needs to be done, like which tools you need to assess. And then, like you were saying, for LD, learning disabilities, there are different types. And if you get it properly assessed, the accommodations in school are also much, you can get that much earlier. So a lot of accommodations are there. They have increased time when they have to write the exam. They can drop a subject if it's difficult. They can have a scribe if writing is difficult. They can use a calculator if there's dyscalculia. If there's dyslexia and spelling mistakes, all that can be excused. The pass mark is a little lower. So a lot of accommodations can be there if it is picked up, which it definitely improves their quality of life. So like even these small ASD kids that come, if they're still ambulant when they come, but once they hear the DMD diagnosis, they don't want to do the occupational therapy and the speech therapy because they're so shocked by the other diagnosis. But there's lots we can do to improve their quality of life in terms of therapies, and also medication, which we can give a trial of, and it will. And so even making protocols for that, there are specific tools that we can use, And even for the learning disability, you don't have to send immediately to the psychologist. There's simple checklists that you can do in your OPD and then maybe send to the psychologist or to the developmental pediatrician, because a screening LD checklist is really quick. So maybe these are the things that we can also share, like which tools to use. Like an MChat is very simple to pick up autism. And there are lots of other, for behavioral issues, there's a CBCL checklist. So there are a lot of tools which are easily available that we can do in a OPD, even if it's busy, which is sometimes it's difficult to assess the children when there's a short time. So it's better if you can be objective about it rather than just subjective. You feel like something is wrong, we'll have better data, and we'll have the baseline also for us.
Yeah,
Um,
thank you. Thank you so much, Neela. We do have a developmental
Oh,
pediatrician.
okay.
Yeah. Yeah.
Yeah.
because we're running out of time,
Yes.
shall I proceed, Dr. Neela? Dr. Umesh, shall I proceed?
Yes, ma'am, please. Sorry if I took time. Sorry.
No, that's okay. I'm going to cut
Ma'am,
short my talk because a lot of it was covered by Dr. Vineet, but some of it, I must confess, they were quite new to me, many of them, because this brain aspect, even if we are aware of it, it still is coming more and more into the forefront. So I thought so it still covers some amount of introduction and the BIND project, because it all comes down to the BIND project. The BIND project has been gaining a lot of momentum since the year 2000. And some assessment tools. I'm not going to go into the details of the assessment tools because, as I mentioned, as Dr. Vineet, Professor Vineet mentioned as well, there are better people, including some of my team members, including the special educator and Dr. Neela herself and other people. So the problem here is not the lack of the therapists or the requisite specialists. It's like you said, many of them come and latch on to only people like Dr. Vineet or me as a neurologist. And development is something that is difficult for me. I have some training, and I'm sure, Dr. Vineet, you're not developmentally trained. And the subset of patients he gets is not the very young, early autism kind of children. So there's a bias in the way children present to him or to me. So I'm speaking from our experience and the management strategies we've used and the way forward. So quick, this is no introduction. We all know this is an educated audience, X-linked recessive disease. And we all know that the dystrophin-associated protein complex is very important in stabilizing the muscle, skeletal muscle, striatal skeletal muscle. But while we do know that it is 1 in 3,500 and that it accounts for nearly 0.1% of the whole genome, the entire DMD gene, which should tell us how important this is. But so while this is we all know it's affected, it is expressed in the skeletal muscle, but more importantly, this is again from the DMD barrier bind, and the DAPC, while the dystrophin, the DAPC, part of the subsarcolemmal protein part, dystrophin is crucial also for normal cells, normal functioning of the cerebellum, as Dr. Vineet had mentioned, the Purkinje cells. I found this an interesting read. This is from my previous boss, Professor Muntoni, and this was, I'm going to use two articles as contrast. This is nearly 23 years old, this article. And I know Prof was really fascinated by the non-muscle phenotype of Duchenne muscular dystrophy. We know this as a severe muscle wasting disease affecting skeletal muscle, cardiac muscle, and brain. But the point that they were trying to get to was that there are specific isoforms of dystrophin. So like a true scientist, he was going down to see, can you break down the science of it? Can you break down and see where is it expressed in the brain? We do know it's expressed in the brain and the retina, but there are like the previous speaker had elaborated, that we do know that certain areas of genetic mutations or variants can cause a variability in the way you get behavioral phenotype, a neuropsychiatric phenotype. So then this gene has got multiple transcripts, and the expression is very cell and tissue specific, and is very specific with regards to embryonic development, from embryonic life to fetal life to as you go on to adult life. And there are 7 important promoters that do that. As you can see, this is from an older paper. And you can see the 7 promoters there, and then you have the vertical lines there. And the cognitive problem that one sees in Duchenne muscular dystrophy is a spectrum. You can have seemingly intellectually normal people, but there's also severe cognitive impairment. And of the one of the studies that I looked at was what Dr. Vineet had quoted, that the mean IQ is 82. I see that even in his study, their cohort of patients, it was below 85. But there is, in quite a few children, it is below 70 or below 50, and very few with IQ above 130. Verbal IQ, as mentioned earlier, seemed lower. Defective memory seems to be there. And there is a milder deficit of a similar nature observed in BMD, which is why we are calling it dystrophinopathy brain involvement. So that's hence comes the 19-country partnered EU-funded project, of which 7 countries. So there is a recent paper that's come out. That is one of the papers that I was hoping to discuss, in which they put in fund using brain biopsies from various parts of the brain and tissues of normal children and studying them at various ages from the brain bank and from tissue bank. So all due to lack of dystrophin or faulty dystrophin. So from here comes, so we need, on one end of the spectrum, we have clinicians like psychologists, neurologists, and psychiatrists. And on the other end, we have researchers like not only Professor Montoni, those working with the MDEX mice, which came up with a fascinating, the study that Dr. Vineet had shown of antisense oligonucleotide to find the shorter intermediate chain dystrophin isoform expression within the brain that would improve anxiety and make people have less emotional and behavioral issues in the mice. The exon skipping in the mice to reduce anxiety. So this was presented in the translation research project in Newcastle last year. So this is the Big 10 and the 4 domains for neurocognitive, emotional, academics, and neuropsychiatric. And we've all got pieces of this puzzle. So this is freely available. So since it's been covered, I'm going through. So we do know that there's ID, there is autism spectrum disorder. So many times when we are taking, as a pediatrician who became a pediatric neurologist, when we are taking our story of the developmental assessment, which is part of our initial assessment, we often get the story that they walked late. They stood at 10 months, but that person, the boy, walked at least 6, 7, 8 months later. Oftentimes, this is because of motor planning and not really a motor delay or weakness that presents earlier on. And this is usually a warning that it is some sort of a spectrum, ASD. And they do have, like Dr. Neela mentioned, ADHD, emotional problems, and reading difficulties. So this too is from another paper, which shows about the expression in various tissues. And as you can see, the full length DP, the isoform dystrophin 427 muscle expressed full length isoform, that's the one that is very well studied. Then the brain isoform 427, that too is studied to a certain extent. What is not as well studied is the intermediate length that is expressed in the retina and the shorter length one, like the 140 and the 116 and the 71. So behavioral problems mentioned previously, but while we know, many of us know that this is difficult, oftentimes families living with DMD comorbidities, these ones have greater impact on them than reduced mobility. But families, even those families who are affected by children who it is so difficult to live with, they feel they're unable to express that it is difficult. So a good example for this is, I remember seeing a child whose mother was very, very motivated. They were they were based in Kolkata. It was a 10-year-old child. And from early onset, this child was nonverbal, was autistic. And they had got a diagnosis. Initially, they went for speech delay. They got a diagnosis of DMD by the age of 3.5. So because it was early diagnosed, and this was a while back, this was nearly a decade ago, the mother then took the child to all the possible centers, specialist centers in the country, Apex Institutes from AIMS to NIMANS to everywhere else. And invariably, they came to us as well. But what then went on was a sad story of a child whose physical ability was not so bad. He was put on steroids, but he was so anxious and had so many other behavioral issues that he took to reducing or alleviating his neuropsychiatric thing with issues with just eating. He was 100 kgs at 10 years of age, and they could not move him or mobilize him. He became too big for them to try to get him to any sort of shape of help. So that really impacted their life more than anything else. But they could not express, or because they wanted to fight for his life, they could not express that the burden or the strain, that the chronic disease strain that they were carrying because of his behavioral issues. So we mentioned various kinds of the longer chain that are most of these are present embryologically, but also present throughout life. And there's a role, specific role within the cerebellum, and both in inhibitory and excitatory synapses, signaling, especially the shortest chain ones. But the DMD transcripts now we're beginning to see that it is also present in the human motor neuron cells, the DP140 that is downregulated in the adult brain. So this is a well-studied isoform, the longer, the full-length isoform that's present in the muscle, the brain, and the cardia, the cerebrum, the cerebral cortex C, the intermediate length one and the short length one, the 70s and the 40s. So thanks to the MDEX mice, we have many of our answers, many of the questions that we had, answers have been answered by this. And so this is the recent paper from Professor Montoni and Dr. Rahul Fadke, who's a neuropathologist based in Queen Square. So Dr. Fadke seems to have extensively studied brain biopsies and expression. And they've come to a conclusion. This is a 28-page article. If anyone's got the time, maybe even look at some of the pictures. They're really beautiful. And the conclusion is that in the hippocampus, and particularly in the Purkinje labors, they found a lot of speckled distribution, and that there's expression of dystrophin. Mainly they were able to demonstrate in the various glutamatergic neuronal populations this was expressed. And this seems to be where we're getting at. The whole idea was that spatially as well as temporally in the developing brain and in the adult brain, you can see on the left side and the right side, there is varying expression of these various isoforms. They were able to do an RNA-scope to demonstrate this. They used immunoblotting extensively to do this. So this is from this. I wanted this is a small subset of 6 children that we had studied, which we had just published, which we had just presented this few weeks ago. And Ms. Veda was the main person who was the architect of this. She's a special educator, and thank you, Ms. Veda, for being present today. So what we wanted to highlight was, in this, of nearly 600 children plus children that we follow, more than 80% of our children come from out of our catchment area. Being in Bangalore, most of them come from other cities or even other states. Of these who were based in Bangalore, a small proportion, we were able to catch 6 children who had a range of young children who had a range of learning related difficulties. And then we saw that primarily in academic prerequisite skills, they had poor sitting tolerance, some issues with fine motor skills, the thing that Dr. Neelia was emphasizing on, reading, writing, spelling, social behavior. And then what we did was, these families, we were able to get them to agree to giving consistent and consistent remedial support for a period of 12 to 18 months with at least 2 sessions a week and additionally a home structured program. So a Brigance assessment tool was what was done by Ms. Veda, pre and post intervention. And then what was noted was there was improvement in all domains. And the children received positive feedback both from school and home. And the parents noted that they were happier, confident, and were able to scope more. So this was a big eye opener for us, and we're hoping to incorporate this more. So but in a country like ours, where they come only to specialist centers, ostensibly to improve motor outcome and reduce mortality and morbidity, it becomes a bit challenging doing this. So often behavioral learning and cognitive issues are not seen as priority, and we have predominant group of non-resident patients. So nobody sees Big 10. So while we do know that the reality of DMD survival in the 15s, in the death by first decade, second decade, is changed to people living in the fourth and going up to the fifth decade, this is not the reality for children who are affected. Varying studies say 50% affected, but some studies even say 70% affected. I'm certainly seeing more than 50 in our patients. Most of them have something or the other, but we do know that they have poorer outcomes, especially with regards to if they have anxiety or if they have inattention. So one stark reminder was what happened 3 years ago. I'm calling it a tale of two twin brothers. They both had they were fraternal twins. They had exon 48 to 50 deletion. They were young. They came when their motor ability was fantastic. On a good time, their 6-minute walk test was above 400. So they were technically amenable for eteplirsen or 51 skipping. This was at the time when our center was recruiting patients for the eteplirsen skipping. But what then happened was one of the twins, who was actually had a higher burden of intellectual disability or cognitive problems, he got selected, and the twin who was cleverer was not selected. he had to be removed from the study because his inattention was making it difficult for him to follow the sets of instructions we were giving with regards to physiotherapy assessment. So the quality of life outcomes. So I'm ending this talk with some generic philosophical things, saying that there's so much of chronic resource burden, financial hardships, caregiver strain, social exclusion, and heavy healthcare dependence in a self-funded healthcare. And this, we don't seem to have culturally relevant QOL to quantify struggles. So I wanted to end this. And okay, before that, sorry, before this had to come here. Sorry, so we thought that some of the tools that we needed to assess was cognition, behavior, learning. And this is different between 3 to 5, 6 to 8, and more than 18, greater than 18. The cognition seems to be the one. Even in the BIND study, where they had the 19 centers, when they compared centers, they found that only Wechsler was common for everybody. Each of the centers had their own toolkits for behavior, for assessing behavior between 3 to 5 to school-going age, to older children, to adults, your young adults, and the learning. So management strategies, obesity, anxiety. So we often find that when they're very little, when we are following them as young children, if they're tending to put on more weight, which is disproportionate to, we do know that children do put on weight when they're about to lose ambulation or go off their legs. But if it is without that, then we know that it is often to do with anxiety. So this is where we generally tend to put our children far quicker on methylphenidate. But this has been our practice, the practice at our center. And we also find that if we do the remedial preschool one, they tend to have better outcomes with regards to weight as well. So the neuropsychopharmacology is personalized and is given in our setting, but I don't have a simple answer to give, but we do think about it. So one of the things that Ms. Veda mentioned, and I would ask her to comment on this, Ms. Veda, if you're there, is what she did with the 6 children that she had worked with. While we are talking about all the weaknesses, one important thing is the specific strengths that each of these children have. If we identify them and nurture that, they seem to take so much pride in it, become confident individuals, and it becomes a source of pride and joy for all concerned, including us and the family. So this is the ending. So we thought, to improve quality of life, can we propose something for us? This is for many of our children, where Dr. Vineet mentioned he's in a tier 2 city. We are in a tier 1 city. Even in a city like ours, we're finding that the vast majority of children, far too many tragically, are going off school the moment ambulation comes into, loss of ambulation, LOA comes into the picture. So we thought, instead of getting into very refined scores, the quality of life scores, which don't seem to be culturally relevant to us, could we come up with a questionnaire to, can a bunch of us come up and ask, is the child relevant or not, ambulant or not? Has the school attendance dropped? And is motor ability the reason? And is there accessibility to toilet? Is that affecting their school attendance? And is the school disability friendly? And I'm sure the majority of the answer is going to be overwhelmingly no, but it would help if we can get this printed out in print, and it might help in advocating for our children. So to conclude, so the non-brain issues in DMD will add increased burden as these children survive longer. And this puts raised expectation on us in advocacy and in improving quality of life. And increasing awareness among parents and medical fraternity is needed for better interventions. And DMT's disease-modifying therapies make the issues even more imperative for all of us. Lots of challenge, but this might help. Tackling the non-muscle phenotype might help us with raising quality of life. Not only for DMD, it could be the prototype for other rare diseases. Thank you. This is the team I'm very proud to work with. Thank you.
Excellent talk, Dr. Ann and Dr. Vineet. The forum is open for questions. We can have five minutes questions, and then we can stop. There is one.
May I ask Miss Veda to make a point, because the work that I presented was hers. If she wanted to talk about one child, Miss Veda, would you be able to talk about this child?
Yes, ma'am.
She's our special educator. She's the one who worked with these children for 1.5 years.
Camera on, says.
Ms. Veda, would you mind switching on your video?
Yes. Hello, everyone. Good evening.
Good evening.
So this is a special case where ma'am was telling about. So this, we have worked for 3 years with this, related with the speech, with the physiotherapy. Now the child is, going for the clinical trial. So very nicely, the child is evolved, is able to, his improvement seen in his reading, spellings, communicative skills, and socializing skills.
That's really nice. Thanks for sharing, Veda.
Thank you. Thank you.
Yeah.
Dr. Anne, I wanted to ask you, the twins that you talked about, the one with the lower IQ got enrolled for the trial.
Yeah,
So
interestingly.
did his IQ improve? Did his did you see other improvements? I know that Vineet mentioned that certain gene therapies which include a certain region would help, but because it could be a breakthrough in ASD actually.
So
If we
that's an excellent point. But to be fair, I am seeing this child every week for the last 3 years. I could not bear to ask them to come for one more test. But now that the trial is ending, we can think about doing that.
to see if his IQ has improved
But
and his behavioral symptoms.
his behavioral symptom, he's just grown older and matured. I didn't think it was improved. To me, it still didn't seem improved. But his older twin was really heartbreaking. He was just anxious. He knew what he was doing, but he just wouldn't follow instructions for the physio assessment.
So why didn't you start him on MPH and then enroll him for the trial?
The trials
With
are very
high
strict that
phenidate.
way. They're very strict that way. They don't allow you. Dr. Umesh knows the answer. He's also part of the trials. You have to
Yeah.
have a stable dose for 12 weeks. We don't get that
Yes.
kind of time.
Okay.
So Dr. Gauri has asked steroid and she has mentioned that few kids becomes cheerful after starting steroids.
Yeah.
I think
I'm not sure, but I do notice that when we give them steroids initially, it's not cheerful. It's just that they feel less aches and pains. They're able to do a bit more stamina. Is that the answer?
yeah,
That
even I feel so.
Yeah,
Because
Maybe.
yeah. I don't know, Dr. Gauri. Anything else? I'm not sure.
I mean,
somebody
even
asked,
regular kids, I mean, like when we start them, like for nephrotic or something, we start them on steroids. They also get quite happy for a short while. I don't know if it's like a neuropsychiatric symptom of
Okay, of
steroids.
steroids. Okay,
Yeah,
sure. Happy pill.
happy pill. Ma'am, this theoretical question about deflazacort versus prednisolone, because deflazacort doesn't cross the blood-brain barrier and prednisolone does. So is there theoretically a difference in behavioral symptoms using both?
So I'm going to ask both of you.
Yeah.
I've not seen any. I can say this mainly because when I was in England at that time, we were predominantly using prednisolone. And now predominantly, that's nearly 4-5 years I remember seeing it, those children on follow-up. And there also, there was a small subset of children using deflazacort. And now here, for the last more than decade, I'm giving only deflazacort. Hardly 1 or 2 children on prednisolone. I've not seen any difference. Would you like to answer that, Dr. Umesh and Dr. Vineet?
yeah, that's what we are using. We have shifted to deflazacort, and we have seen there is not much difference what we have. In fact, the side effect profile is much better with deflazacort regarding the other physical parameters. But behavioral, we have not seen much difference. I don't personally feel that, as you mentioned, the steroid has definitive role. It might be just because of the well-being that the child is improving, his goer sign has improved initial few days, so they might be more cheerful. They're able to do more physical activity. So that might be the reason. But that point Vineet mentioned is very interesting, that in exon 51 and then exon 53. So something that, but what I feel overall, if 51, at least we will be able to give that, and if it will increase the dystrophin exposure, so might improve the brain
This was
function.
a breakthrough. They were so excited about their mouse model. They were showing off their mouse model with exon skipping, where they reduce the anxiety in the mouse.
Yeah, that's what.
Yeah.
But this is a very good talk. Actually, this is very important, as we will be going into future about genetics, exon skipping. So this part of the aspects of the DMD, we hardly in India we think about it. Many times we just struggle with the diagnosis and then managing the basic things. So this is something which we should start doing, collaborative studies.
While we do this basic, one of the things that I wanted from Dr. Vineet as well, and actually he inspired me to want it, is that, he's got an older bunch of, almost all of them are on wheelchair, no, Dr. Vineet?
Yeah,
Your
yeah.
children?
Mine are non-ambulatory.
All non-ambulatory. So if you, mine not all are non-ambulatory. So maybe about 30% of my children are non-ambulant. The rest are all small. So if we can, and it will take our therapists. I see that they're all here, Miss Sneha and Sharanya. They were the ones, and Miss Gauri as well. So they are physiotherapists. They were keen to do this. And if we can, get a questionnaire. Those are the 5 questions that I put in the end. If we just simply do that and say, this is the gap that we have to bridge, do you think we could do it? And we could we could have a Zoom meeting, the 3 of us, and say, this is what we'll do. And then it will just take 2 days for them to sit down, talk. We can get consent for telephonic consent and do it off and get it written up, collect the data. Do you think we could do something like that?
Yeah, yeah. Of course, we have all the contacts, everything.
Yeah, we also have contacts for all our patients. Dr. Umesh, you think somebody can do it for you? Because it's just a 5 or 6 questions to be administered to the patient. And we might be able
Definitely
to
we
get,
can. Yeah, definitely we can try. Definitely. This is something which we will try.
Yeah.
then we come up with a date where we meet, and
Yeah.
we then we just it will not take us more than half an hour to do it.
Yes.
We
Yes.
validate, then we say we go back, we get ethics committee approval, and we do it.
This is a good. Actually, this is something which, if you have so much of data, why not to analyze it?
But Dr. Vineet, you have more experience than any of us in academics.
Yeah.
So
Yeah.
I'm hoping
Definitely.
you'll help.
No, I'd be happy
know.
actually. I had some for the question. We can formulate a nice, we need to do a
Nice.
few steps before administering it straight off. We need to just, take it through expert opinion, do a Cronbach's alpha, make sure it's all properly done. And then,
Sure.
publication also will be better rather than
Okay.
just asking those questions.
No, so this is
upfront.
just the first step. I said
Yeah,
desire,
yeah,
and then
yeah.
we start.
No, it has been something for me very important. See, when we started doing the work in Duchenne's, I was wondering whether I should send a genetic test or not. That's how we began 10 years ago. Because I was like, what's the point in, it's Duchenne's, you do genetic testing, kya karega? We're just spending their money. It used to be expensive those days. So anyway, that's how we began. Somebody gave some fund saying, okay, bhai, tu is fund se kara le. You don't do, don't charge the patient. But then that's how the experience grew. And also, the what hope do you have to offer? You have nothing except that this child is going to die eventually. So and it's a slope downwards. There is nothing going up. It's a slope downwards. Just whether it's like this, you can make it like that. And that's my chart in the, that just keep drawing them. This is what the whole thing is about. But I think when we are talking more and more about young adults, childhood, that they're growing, they can go to school, they can go to college, and now we have some examples of people doing engineering, becoming doctors, so those things inspire. Today, I had a kid in the OPD, he's 15 years old, he's non-ambulant, he got a motorized wheelchair. Again, somebody funded it for him.
Nice.
He's going to school now, and so those are things that kind of make it meaningful. Otherwise, this can be quite a challenging space.
It can be quite negative influence only and nothing else. That's like
Well,
some of my colleagues saying, why are you seeing only these kind of children in your OPD?
yeah, like somebody did ask a question. I think there is a question in the chat talks
Yeah.
about
There is.
cost.
Dr. Krishna.
What is the cost burden of treatment for cognitive impairment? It's a very everything is about cost. There are actually now papers on pharmacoeconomics in Duchenne's. I think from India also, it'll be good if we give the whole standard of care. How much will it cost them across their lifetime? Were they to live, like you can say 25, 30, the average.
This pharmacoeconomics is one of the things that I talk to my families, not just in pharmacoeconomics, to say many of them end up paying. Everybody, if they're from a middle class family or a slightly higher middle class family, they will spend a few lakhs to get an admission in a school. So I try telling them early on, don't do that. More important is your remedial education or your early intervention. That is
Yeah.
more important than school, because your school, you will stop thinking of it as a status symbol and it'll drop.
Yeah.
So invest in time. So we should be able to pick it up early and guide them that way.
Yeah.
So I feel economics, ultimately, why are parents alive? We are there for children only, So you're going to have to plan your life around this. Itna budget hai, itna karna hai, aage kya karna hai. And Dr. Krishna has also asked about, do steroids worsen cognitive function in DMD? Not that I have seen. Would anybody else want to answer that? steroids not worsening cognitive impairment.
Yeah, just the irritability is what I have seen.
Well, I haven't seen that. Most of the times, it seems to be the vast majority of children don't seem to have it. They seem to have the irritability before itself. Very small, like less than 1%. The pure the
How do
steroid.
you go with the steroids?
Yeah, but we are not giving such big doses of steroid.
Yeah,
You're giving much smaller doses of steroid.
very
They
low
don't.
doses.
Yeah, yeah,
It's not enough to cause neuropsychiatric symptoms. There was
yeah.
a study that was done that said DMD with NDDs, neurodevelopmental disorders, their lifespan is actually 7 years shorter than if they did not have.
That's what I was alluding to. Not only 7 years,
Yeah.
it's much less. Like I told you about the
So
10-year-old, 100 kgs. That child is not going to
yeah,
15 is average. He's not going to last 15.
yeah.
Yeah.
Yeah, I
So
think,
That's
I'm
the part.
seeing more and more children who are very short lifespan, they die by the time they're 11, 12.
Yeah.
And they are non-ambulant by the time they're 7. That is so odd, I mean, based on Western literature, where Western literature 19 was the average before treatment. I mean, India to average with whatever, I mean, it is so low. I think there is some
But
genetic or,
no,
yeah.
I don't think so, because I've seen some of those children as well. They come first time to us. On the same way, I've had like a bunch of children who are walking till 15 and 16. So much so, 3 years ago, I thought I'm making a mistake in diagnosing them. So I went to Professor Eugenio Mercury and to Professor Montoni as well and said, are we making a mistake? So we even presented something recently saying that, those with question marks, we did 5 of them, we did a muscle biopsy and proved that dystrophin is totally absent, even though it was out of frame mutation. It was some were totally absent, but some of them, they was partially present. So we reclassified them. But he said it is because we are earlier intervening. The ones who are walking at 7, they're coming to us late. We're starting steroids late.
Yeah, but I mean, I don't know. I've not seen enough of Duchenne's, but what I feel is that there are certain patients who are much rapid decliners, and there are
Yeah,
certain
that
patients
is
who
true.
are
Yeah,
slow. That's the range.
yeah.
And if we can
Seems to
predict,
be.
if we can predict based on certain biomarkers early, then we can counsel the families accordingly. Like you said,
Correct.
like
Yeah,
those
yeah.
with neurodevelopmental delay would probably have a shorter lifespan, so, and cardiac maybe, and respiratory, maybe, those things.
Does the dystrophin in the retina affect vision?
Not that we know of.
So
We know of
what
that?
does it do in the retina?
I guess we should
Or
ask some of our retinal specialists to see if they're seeing depth perception or color differently.
Because
Yeah.
does that affect their learning and their behavior and things like that also?
Interesting. Don't know. Don't know.
Yeah, I'll read up.
So, Dr. Vineet, that was your talk was hats off. Really, really hats off.
Yeah. Thank you, Vineet. It was so nice. You went all the way through.
Thank you very much.
I think no questions. Excellent talk from the speakers. Eye opener. Definitely something which you start implementing apart from clinical work. So thanks, Dr. Vineet, Dr. Anne, and thanks Anne again for organizing such a beautiful talk every month. You're taking efforts to teach
Next
something
time we don't have
else.
to do this much effort. It'll be WMS highlights next time, next month.
Yeah. But that
Next time.
we are eager to know what new things are happening in WMS. So I think if there are no questions, we can stop here. No, I
But
can't
I'm
see
going to
any
say
question.
thank you to Dr. Umesh and Dr. Neelia. Dr. Neelia, thank you for adding all those nuances and flavors. The thing is, we all need to be working together. We all work in different institutions. That is the problem. So maybe we can
Yeah.
work more together. Yeah. Thank you. And thank you, ORDI, for providing the platform. Thank you, Dr. Umesh.
Thank
Okay.
you.
Good night,
Thank
everyone.
you.
Yeah.
Good night.
Bye.
Bye-bye. Bye.